Renal tubular acidosis refers to a group of disorders where normal tubular function is compromised, leading to a metabolic acidosis with a normal anion gap. In the preliminary assessment of normal anion gap metabolic acidosis, leveraging the urine anion gap can help distinguish the RTAs. The urine anion gap is calculated as the sum of urine sodium plus urine potassium minus urine chloride. Type 1 renal tubular acidosis occurs in the distal tubule due to inadequate proton secretion by alpha intercalated cells, and it has a positive urine anion gap. Type 2 renal tubular acidosis occurs within the proximal convoluted tubule, where bicarbonate reabsorption is impaired. Urinary bicarbonate loss is the hallmark of type 2 RTA, and often has a negative urine anion gap, which differentiates it from types 1 and type 4 RTAs. Fanconi syndrome is a significant cause of type 2 RTA as it results from damage to the proximal convoluted tubule, which impairs reabsorption of glucose, amino acids, electrolytes, as well as bicarb. Acquired Fanconi syndrome can occur with multiple myeloma, amyloidosis, intoxication with heavy metals, or as an adverse effect from a variety of drugs. And type 4 RTA is due to aldosterone resistance or deficiency, commonly leading to hyperkalemia, as well as a positive urine anion gap. This case report revolves around an 87-year-old male with a history of chronic kidney disease, hypertension, multiple myeloma in remission status post-chemotherapy, bladder cancer status post-transurethral resection of bladder tumor, who presented for syncope. On admission, his vitals were stable, physical examination was unremarkable, and the patient was found to have an AKI as well as a normal anion gap metabolic acidosis. Sodium bicarbonate supplementation and IV fluids were given. Nonetheless, the patient's normal anion gap metabolic acidosis persisted. A repeat urinalysis revealed increasing urinary alkalization, continued proteinuria, as well as glucoseuria in a non-diabetic patient. These findings were consistent with type 2 RTA due to Fanconi syndrome, likely acquired from multiple myeloma. Interestingly, the type 2 RTA was initially obscured by the fact that the patient had a positive urine anion gap. As mentioned earlier, type 2 RTAs have a negative urine anion gap. However, the urine anion gap may not be reliable in the setting of AKI, as in our patient, which is likely why he never had a negative urine anion gap. Following a week of treatment, the glucoseuria and proteinuria resolved, indicating that his Fanconi syndrome had reversed. This was unexpected. Acquired Fanconi syndrome can be permanent if there is extensive damage to the proximal convoluted tubule, or it may gradually reverse if the damage is less severe. However, in a patient whose multiple myeloma is in remission, one would not expect such a change. This prompted further investigation for the possibility of multiple myeloma recurrence, as well as exploration of other potential causes of his reversible Fanconi syndrome. With recent bone scans showing no new lesions and kappa-lambda light chain ratio within normal limits, multiple myeloma recurrence seemed less likely. Moreover, after discussion with the patient's family, it was revealed that he received lenalidomide 3 days prior to admission, as part of his chemotherapy regimen for multiple myeloma. Repeat urinalysis confirmed that the glucoseuria and proteinuria had resolved, and the patient was diagnosed with acquired reversible Fanconi syndrome secondary to lenalidomide. Lenalidomide is an immunomodulatory drug that inhibits tumor angiogenesis and harnesses the immune system to target aberrant cells. In 2008, Glezerman et al. Reported a new association between lenalidomide and reversible Fanconi syndrome. In this case report, the patient's multiple myeloma was in remission, and resolution of Fanconi syndrome occurred within a few weeks after discontinuing lenalidomide. Likewise, Wesner et al. Also reported 2 interesting cases of Fanconi syndrome that developed after several months of lenalidomide administration. In one case, the patient's multiple myeloma was in partial remission prior to the development of Fanconi syndrome, suggesting lenalidomide to be the more likely cause of the patient's Fanconi syndrome. Similar to these cases, our patient also developed Fanconi syndrome in close temporal proximity after lenalidomide administration, indicating a potential causal relationship. Much like the stated case reports, our patient's Fanconi syndrome resolved after lenalidomide discontinuation. This case report not only sheds a light on a relatively unknown adverse effect of lenalidomide, but it also underscores the critical importance of maintaining a high index of suspicion when evaluating patients with Fanconi syndrome. The initial resemblance of symptoms to a well-known association, such as multiple myeloma-related Fanconi syndrome, should not deter clinicians from considering alternative causes, especially when the clinical response to conventional treatments is not as expected.